Okay, so let's unpack this. You've shared some really critical source material here, digging deep into diabetes complications.
hmm
Now, we all know the main headline when it comes to managing diabetes, right? Control your blood sugar numbers. It's the cornerstone.
Absolutely. And for very good reason. High glucose levels are the primary driver behind most of the long-term problems.
But what these sources really hammer home is that the story isn't just about that number on your meter.
No, not at all.
There's this kind of hidden war going on inside the body, a silent sabotage driven by that high blood sugar. It's the why behind the complications, isn't it? That intricate damage happening way down at the microscopic level. That's the part people maybe don't hear as much about.
Exactly. And, understanding that microscopic battle, that's really key.
Yeah.
Because if we know how the damage is being done,
And then we can maybe find better ways to fight back.
precisely, more targeted ways.
And this is where the sources introduce a really fascinating twist. They bring in incretins. Now, these are hormones we've usually thought about mainly for blood sugar management, right?
That's been their main claim to fame, yes.
But the suggestion here is they might be these surprising cellular defenders offering protection that goes way beyond just helping with glucose numbers.
Yeah, what's particularly compelling, I think, is this emerging view that these natural compounds and the meds based on them might have this much broader protective role, sort of system-wide.
Okay, so in this deep dive, our mission is really twofold. First, let's uncover that unseen damage, this intricate cellular disruption that high glucose causes.
Right.
And then let's explore how these incretins might actually step in as active cellular protectors, ready to get into the nitty-gritty.
Let's do it.
So where does this silent sabotage even begin? How does high glucose start, chipping away at the body?
Well, it really goes after the body's vital transport system first, the blood vessels.
Yeah.
High glucose causes damage at both the smallest level, what we call microvascular damage, and to the bigger arteries, the macrovascular damage.
Okay, micro and macro. Can you give us some specific examples? Like, how does this microscopic damage show up? What about, say, the eyes or the nerves?
Good question. So think about those tiny, really delicate blood vessel networks. In the eyes, the source describes how these small vessels in the retina can get brittle, leaky.
Ah, diabetic retinopathy.
Exactly. That can blur vision, potentially lead to blindness over time. Then in the kidneys, the body filters those tiny blood vessels, the glomeruli, they get harmed.
Which messes up the filtering job.
Right. It impairs their ability to filter blood properly. And this can just silently creep up, leading to significant kidney disease.
And the nerves. I hear a lot about neuropathy.
Yeah, well, high glucose damages the tiny vessels that feed the nerves themselves, cutting off nutrients and oxygen. That's diabetic neuropathy.
So that causes the tingling, the
Right.
numbness.
Tingling, numbness, pain. Yeah, especially in hands and feet. But it also hits the nerves controlling internal stuff, like digestion or heart rate.
Wow, okay. That's a lot just on the small vessel side. What about the big ones, the major arteries?
Those are like the body's circulatory superhighways. And high glucose significantly speeds up atherosclerosis.
That's the plaque buildup, right?
Exactly. That sticky plaque building up inside these larger arteries, it narrows the road, basically, restricting blood flow.
And the consequences of that restricted flow are pretty serious, I imagine.
Extremely serious. It dramatically bumps up the risk for things like heart attacks, strokes. And in the legs and feet, it leads to peripheral artery disease. That means pain, ulcers that just won't heal.
And potentially amputation risk.
Tragically, yes, it increases that risk significantly.
So it's hitting the entire circulatory system top to bottom. But the source also mentions damage happening even deeper, like right down at the cellular and molecular level. What's going on there?
Yeah, this is where it gets really complex and kind of insidious because it builds up over time. One major player here is the formation of advanced glycation end products, AGs for short.
AGEs. Okay, that sounds ominous. How should we picture those?
Okay, think of it like this. Based on the source, too much glucose floating around. It doesn't just stay put. It starts sticking sort of randomly to proteins and fats all over your body.
So it's like gumming up the works.
Kind of, but worse. These glucose-coated proteins and fats, those are the AGEs. And the source uses this vivid analogy, calls them molecular hand grenades.
Molecular hand grenades. Okay, that definitely paints a picture. Not a good one. What do?
Well, they build up in tissues over years, and they make things stiff like blood vessel walls, nerves.
Yeah.
But critically, they also trigger and fuel widespread inflammation and something called oxidative stress.
Okay, another term, oxidative stress. Before we get there, what else is happening down at this tiny level?
Yeah.
The source mentioned something about a polyol pathway.
Yes, the polyol pathway. So this pathway gets overactive in certain cells, like in your eyes, kidneys, nerves that don't need insulin to let glucose in.
Ah,
So
oh.
when glucose is high, it just floods into these cells, and then a chunk of it gets pushed down this alternate route, the polyol pathway.
And why is that a problem? Is it using up something important?
Exactly. It consumes molecules the cell really needs for its own defense. Specifically, it burns through this vital protective molecule called NADPH.
An ADP.
Yeah, think of NADPH as like a critical battery or fuel source for the cell's internal cleanup crew, the part that neutralizes damage. By using it up, the polyol pathway basically weakens the cell's ability to defend itself
Yeah.
against oxidative stress.
Which brings us right back there. You mentioned it's like rust inside the cells. Can you break that down a bit? What is oxidative stress?
Sure, it's basically an imbalance. You get an overproduction of these unstable molecules called reactive oxygen species, ROS, or free radicals. And just like rust damages metal, these ROS molecules are highly reactive. They attack vital cell parts, DNA, proteins, the cell membranes themselves. It's damaging.
And does that damage just stop? Or does it cause more problem?
No, it perpetuates itself. It creates this vicious cycle of more inflammation, more tissue breakdown.
And the source was really clear that high glucose isn't just causing inflammation as a side effect, right? It said it's an active participant.
Precisely. It's not a passive bystander. High glucose directly flicks on inflammatory switches inside cells. This triggers a state of chronic, low-grade inflammation throughout the entire body. And yeah, it's an active player constantly pushing forward those micro and macrovascular complications we talked about.
Okay, so let's just recap the damage side quickly. We've got blood vessel problems, big and small. We've got these AGEs, the hand grenades, stiffening things and causing trouble, the polyol pathway, using up the cell's defenses, oxidative stress acting like rust, and chronic inflammation basically fanning the flames. Is there anything else fundamental that high glucose messes with?
Yes, one more key thing. High glucose also directly impairs the immune system itself.
How so?
It can make white blood cells less effective, less able to do their job. This makes people with uncontrolled diabetes more susceptible to infections, and it's why wounds can heal so slowly.
Okay. That paints a pretty stark picture of this whole silent sabotage thing. Now, for decades, the main strategy, the sort of battle cry, has been really clear: control your blood sugar.
Right.
And the sources definitely agree lowering glucose is the most effective single thing you can do to reduce these complications.
It absolutely is. It's the foundation. You're reducing the primary fuel for all these damaging pathways we just discussed.
Oh, and this is the big but the sources raise. What if we could also fight back against those cellular and molecular saboteurs more directly? What if there are ways to intervene that might work even if blood sugar isn't perfectly controlled, or work independently of just lowering it?
And this is where the perspective starts to shift, yeah.
Enter incretins. This is where it gets really interesting. Now, we know them as these natural gut hormones, right? Like GLP-1 and GIP, released after we eat.
That's right. When they were first really understood, their main known job was signaling the pancreas to release insulin. But crucially, only when glucose levels were actually high. It's glucose dependent.
So it doesn't cause lows on its own.
Generally, no. And they also help by suppressing glucagon, which is another hormone that raises blood sugar. So that whole understanding led to the development of medications like GLP-1 receptor agonists and DPP-4 inhibitors, mainly for type 2 diabetes.
Right, but the source is saying, hold on, that's not the whole story. It talks about profound pleiotropic effects. Okay, what does pleiotropic mean in plain English?
Yeah, it's a bit jargony. Pleiotropic just means having multiple effects or actions. So it means these hormones and the related medications seem to have benefits that go well beyond just managing blood sugar.
Benefits like directly fighting that cellular damage we were just talking about.
That's the core idea, exactly. They seem to act as active cellular defenders. The sources point to several key ways they do this, especially the GLP-1RAs.
Okay, like fighting that rust, the oxidative stress.
Yes. They seem to be potent antioxidants themselves. They can directly neutralize those damaging free radicals, the ROS.
So they clean up the rust directly?
They can, yes. And they also seem to boost the body's own internal antioxidant defenses, helping produce more protective enzymes, like one called superoxide dismutase. Plus, of course, by helping improve glucose control, they indirectly cut down the fuel for oxidative stress in the first place.
So it's like a multi-pronged attack against the rust.
You could put it that way, yeah.
Yeah.
Protecting the cellular machinery from multiple angles.
Okay, what about taming that chronic inflammation? That sort of silent fire you mentioned.
Yeah, incretins seem to act almost like cellular fire extinguishers against that low-grade systemic inflammation.
Really?
Well, clinical trials have actually shown significant drops in the levels of key inflammatory markers floating around in the blood, stuff like C-reactive protein, TNF-alpha, IL-6.
Those are things doctors can measure.
Yes, exactly. And mechanistically, they seem to modulate how immune cells behave, kind of calming them down, and they can inhibit major inflammatory pathways inside cells, like one called NF-kappa.
So the end result is less body-wide inflammation.
That seems to be the case, which in turn helps protect blood vessels and organs from inflammatory damage.
What about those AGEs, the molecular hand grenades that make things stiff? Do incretins help there too?
Well, the main way they help is pretty straightforward. By reducing the amount of time tissues are exposed to high glucose, you just form fewer AGEs to begin with, less raw material, fewer grenades.
Makes sense.
But interestingly, there's also some growing evidence, mentioned in the source, suggesting they might have more direct effects too.
Like what?
It's still being researched, but it might involve influencing how AGEs actually interact with their receptors. There's a key one called RAGE, receptor for AGEs. When AGEs latch onto RAGE, it triggers a cascade of damaging signals. Incretins might interfere with that binding, or maybe dampen the harmful signals that get sent.
Huh. How do they even measure that?
Well, the source mentions studies using things like non-invasive skin autofluorescence, which is a way to estimate AGE buildup in the skin, showing reductions with incretin therapy. So there's some clinical data pointing in that direction.
Okay, so reducing AGE formation, maybe messing with how they cause damage, it really sounds like they're fighting back on multiple fronts against those core damage pathways.
It seems that way.
Mm.
And importantly, it's not just about protecting other tissues. They also seem to directly benefit the very cells that get worn out in type 2 diabetes, the insulin-producing beta cells in the pancreas.
Ah, so helping the insulin factories themselves. How do they do that?
Well, they appear to improve the function of the existing beta cells, make them work better, and might even help improve their survival, reducing how quickly they die off.
Which is huge in type 2, right? Because beta cell failure is kind of the core problem over time.
It's a central part of the progression, yes. So by fighting that exhaustion and failure, they can help the body maintain its own insulin production for longer. That leads to better long-term glucose control, less stress on the system overall.
Okay, so that's the theory. The proposed mechanisms fighting oxidative stress, inflammation, AGEs, helping beta cells. What about the real-world proof? Has this actually translated into measurable benefits in big studies?
Oh, absolutely. This isn't just lab bench stuff anymore. The source really highlights the results from those landmark cardiovascular outcomes trials, the CVOTs. These were huge studies involving thousands of people with type 2 diabetes, looking specifically at GLP-1 RAs.
And what was the big takeaway from those trials?
Well, the really remarkable truth that emerged was this. These medications didn't just lower blood sugar. They significantly reduced major adverse cardiovascular events, things like heart attack, stroke, and dying from cardiovascular causes.
Okay, that's significant.
But here's the kicker. The size of that benefit, that reduction in events, was often greater than what you'd expect just based on how much they lowered blood sugar alone.
Ah, so that points to something else going on.
Exactly. It provided really strong clinical evidence supporting these direct protective effects on the heart and blood vessels, effects happening independently of just the glucose lowering.
Wow, that must have really changed things.
It fundamentally shifted how these drugs are viewed and used in practice, yes. And it wasn't just the heart. These studies also showed benefits for the kidneys.
Like preventing kidney disease.
Reducing the progression of diabetic kidney disease, yeah. And improving markers like albuminuria, that's protein leaking into the urine, a sign of kidney filter damage. So again, it backs up the idea of direct anti-inflammatory antioxidant effects happen right there in the organs.
Okay, so if they have these powerful protective effects, potentially independent of blood sugar control, does it make sense to use them earlier? Like maybe right when someone gets diagnosed with type 2 to try and head off this damage before it really takes hold?
That's a great question, and the source gives a pretty strong yes to the idea of early intervention.
What's the rationale?
Well, the thinking is that diabetic complications, especially the structural damage, take years, even decades, to build up, and a lot of that damage can become irreversible over time.
So get in there early.
Right. By introducing these agents early on, you're activating those cellular protective mechanisms, the antioxidant, the anti-inflammatory effects,
Hmm.
the vascular benefits, right from the initial stages of diabetes, potentially when tissues are still more resilient and damage hasn't fully set in.
You're basically deploying the cellular defenders before, or just as the silent sabotage is really getting underway.
Exactly. You're leveraging these positive effects early and consistently over the long haul. The hope is that this can prevent or at least significantly slow down the progression towards irreversible damage.
And those big CVOT results seem to support that long-term benefit idea.
They really do. They underscore the potential power of applying these direct protective effects proactively. And you see this reflected in treatment guidelines. Now they're increasingly recommending GLP-1 RAs earlier, especially for people with type 2 who already have heart or kidney issues or are at high risk for them.
Now, this deep dive is for you, the listener, and we know many people listening might be living with type 1 diabetes. Does any of the cellular protection talk apply to type 1? The source said the landscape is more complex.
It definitely is more complex, primarily because type 1 diabetes involves the autoimmune destruction of those insulin-producing beta cells. So insulin therapy is non-negotiable. It's absolutely essential for survival. Incretins can't replace that.
Okay, clear distinction. But
Yeah.
is there any role?
Well, research is actively looking at using incretins, particularly GLP-1 RAs, as adjunctive therapy in type 1.
Adjunctive meaning used alongside insulin.
Exactly. Used in addition to optimized insulin therapy, not instead of it. The idea is to leverage some of their other beneficial effects that aren't dependent on stimulating insulin release from beta cells because, well, there aren't many functional beta cells left.
What kind of non-insulin effects are helpful in type 1?
Well, for example, GLP-1 can still suppress glucagon secretion in type 1, which helps prevent highs. It also slows down how quickly the stomach empties after eating.
Which would flatten out those post-meal sugar spikes.
Precisely. That can contribute to better overall glycemic stability, smoother numbers, and they can sometimes help with weight management, which can also be a factor for some people with T1D.
Okay, so some glucose stability benefits. But what about those direct protective effects we've spent so much time on? The anti-inflammatory, the antioxidant stuff protecting blood vessels and organs. Are those thought to be independent of insulin too?
Yes, and this is really the crucial point for type 1. The sources emphasize that these core cellular protective effects of GLP-1 RAs, the antioxidant, anti-inflammatory, potential direct vascular benefits are believed to happen independently of stimulating insulin secretion.
So because the receptors for GLP-1 are found all over the body.
Right, on blood vessels, heart cells, kidney cells, immune cells, the potential for these direct cellular benefits still exists in people with type 1, even though their beta cells aren't the target.
So the idea is, even without functional beta cells, the rest of the body could still potentially get that extra layer of defense against long-term damage from high sugar or just the state of having diabetes.
That's the biological rationale, yes. And there have been smaller studies in type 1 looking at this. They've shown some positive signs, improvements in cardiovascular risk factors like blood pressure or lipids, maybe some reduction in albuminuria, suggesting potential kidney protection.
But not the huge CVOTs like in type 2 yet.
Not yet on that scale for type 1, no. We still need those large long-term trials to definitively prove that these agents reduce major complications like heart attacks or severe kidney disease in type 1. But the biological possibility, the reason to believe they might help mitigate long-term damage through these direct cellular effects, is certainly strong.
Okay, so just to be absolutely crystal clear for anyone listening with type 1, incretins are not a replacement for insulin.
Absolutely not. Cannot stress that enough. They are not a cure. They do not replace insulin. They're being explored and sometimes used carefully by doctors as an adjunctive tool, something extra.
Offering potentially valuable add-on benefits like maybe smoother glucose, and importantly, that potential extra layer of cellular protection against the long-term complications working together with good insulin management.
That's the hope and the focus of ongoing research, yes.
This has been incredibly insightful, really peeling back the layers here. It does bring up a very practical question, though, and I saw this echoed in some source comments. If incretins offer this cool cellular defense, how does that stack up against just doing a really good job keeping blood sugar numbers in range? Like, what's relatively more important, push come to shove?
Yeah, that's the million-dollar question, isn't it? And the honest answer, which the source acknowledges, is we don't have definitive head-to-head data to say, this factor is worth X% and that one is worth Y%.
Okay, so no perfect numbers, but What's the best guess, the speculation from the source, based on everything we know now?
Well, the speculative thinking, based on the current weight of evidence, is that maintaining a good time in range, keeping your blood sugar within your target zone as much as possible, is likely still the single most statistically important factor for preventing the bulk of complications overall. Good glucose control remains paramount.
But there's a however.
There is, and it's a key nuance. The source suggests that even with reasonably good time and range, adjunctive therapies like these incretins might still be significantly helpful. They might help reduce the lingering effects of, quote, basically having diabetes.
Meaning that even with decent numbers, complications aren't completely off the table. Some damage might still be happening.
It seems plausible, yes. Diabetes is complex. Even with good day-to-day management, there can still be some underlying metabolic stress, some low-level inflammation or oxidative stress accumulating over years. So incretins could offer an added layer of protection against that ongoing, perhaps more subtle damage.
So complementing good control, not replacing its importance.
Exactly. Think of it as potentially another tool in the toolkit, working alongside, not instead of diligent glucose management.
Okay. So to kind of wrap this deep dive up, the big picture here is that diabetes complications are way more than just a number on an A1C test. It's really a story of this persistent, silent cellular sabotage damage to blood vessels, those toxic AGEs forming, oxidative stress, chronic inflammation.
A whole cascade of damaging events, yeah. But the really exciting counter-narrative emerging from the research, which these sources highlight so well, is that incretins offer this powerful, active cellular defense. Their role seems to go far beyond just helping manage blood sugar.
They appear to directly fight back against those fundamental damaging processes we talked about.
Exactly. And while they're now a cornerstone therapy in type 2 diabetes for many,
Right.
for those with type 1, there's this really promising research looking at their potential as an adjunctive therapy used alongside insulin, potentially offering those same crucial cellular protective effects against long-term complications.
It really does encourage us all, I think, to think beyond just the numbers on the meter or the CGM graph, doesn't it? And to consider actively protecting the body's intricate cellular machinery right from the ground up.
It's a shift in perspective for sure.
Which kind of leaves us with a final thought for you, the listener. If the future of managing diabetes is less about solely hitting target numbers and maybe more about actively safeguarding every single cell in the body from this ongoing damage, how does that change your perspective on living with diabetes day to day, or perhaps supporting someone who does?